Well, has everybody had fun? I told you the amount of conversation it takes for having fun. I'm having fun. I really enjoy it. Okay, so as you can see, this is a work in progress. The title totally changed between the time that I signed up, because now we have a name for the program, so we're calling it Let's Go, which is supposed to be like, we'll have a fancy, beautiful, I loved the logo for the health unit. I gotta find whoever designed yours because I want to think of a fancy logo. But anyway, so this is the name of the program. You know, usually we're talking about doing research and then having knowledge translation. So this is exactly the opposite. So what happened was I was sitting at home. This is the overview, so I'll tell you about how this came about, and then talk a little bit about how we're using this to enhance research in community setting and the opportunities for professional education, as well as how this can help to kindle changes in your environment, wherever you are, and how we can improve the community's health that way. So I was sitting at home, minding my own business, reading the American Journal of Psychiatry, and I read this amazing study called the STRIDE study. And what really amazed me about the study was it was so simple, it was so inexpensive to do, and it was a very effective study. Now, you know, I read other studies that same month about having people go to buying them a gym membership and having a personal trainer every week for a year, and I'm thinking, and the results, they had some results, but they weren't that impressive. And I'm thinking, we couldn't afford to do that. How would we do that? But this was a very simple intervention, very effective. Now, so I'm going to warn you. There's a number of warnings with this. I have to, you know, to tell you. I have no interest, conflicts of interest to declare. But I will warn you that this can be dangerous to your health, or it can change your whatever, change your, as you say, your day job, in fact, your day job. So you start reading these things, you start thinking, well, maybe I could do this, you know, at home. Usually they tell you not to try that at home. I decided to try it at home. So basically what these folks did was they recruited a large number of patients in several outpatient settings, and they obtained their consent, they collected some data, and then they had a very simple intervention. They got them together every week. They spent a few minutes teaching them about diet. They had 30 minutes of low-intensity exercise. I think at first they had somebody leading, and then they had a tape. Pretty low tech. And then they had group behavioral support. Now, looking through the research is interesting. I'm really fascinated by this idea about the online thing. But the group thing is also very important. So this is what you're going to look at. And so I was very struck by this. There's something about the group was helpful, and that you used motivational things such as little rewards and having people journal. We know that having people write down what they eat is one of the effective ways to change behavior. Now, and here's the other thing. So, you know, who's had a gym membership, right? These folks only went on an average of 14 and a half out of 24 sessions, and they still did very well. So even though they didn't go every week and so forth, they actually had 4.4 kilogram greater weight loss than the other group, and much better just general health. So this wasn't just about losing weight, it was about being much more fit. And even at 12 months, so they only did it for 24 weeks, but when they went back and checked at 12 months, they had still lost a considerable amount more weight than the intervention group, which was just a treatment as neutral. Now, I'm a psychiatrist, so I see a lot of people with serious mental illness. Many of them are on atypical antipsychotics. They all have trouble with their weight, and this kills them. It kills them. Their mortality rates are two to 3 times as high as the rest of the population. They die from cardiovascular disease. They die from their lifestyle. And they have great cognitive difficulties, which make it hard for them to adhere to a program. They often smoke first, because nicotine is one of the few cognitive enhancers we know of that helps when you have no executive function. So I started thinking, it was the second morning, those who know me, Jamie, Margaret, have learned to get very nervous when I start thinking, I have an idea. They know what's coming. So you have to have supportive colleagues like these two. And here are 2 supportive colleagues to begin with. One is Joe Carr, wonderful mental health director of all the programming, and Sadia Ahmad, who's the head of our outpatient department. And I said, hey, you know, what would you think about trying to do something like that here? And they said, great, let's do it. So that was wonderful. And Joe said, well, you know, we might need a few dollars to give a little Tim card or something, and journals and chronometers and stuff. So he had some ideas about that, and he said he'd present the business plan. So just to tell you a little bit about our facility, so we're a large rehabilitation center, really. We have a large tertiary bedded hospital for mental health, but also a big rehab unit, a complex continuing care unit, and some outpatient services that go along with those three main areas. And although research is really something that's on the radar, especially for our board, it is not something that's a day-to-day experience for folks there. So as I was Santa Margaret, I'm in a community institution that's turning into an academic institution, because now we are more and more involved with the medical school, with residents and so forth. And the administration has appointed a great research and project coordinator who's very keen. And we have natural partnerships with folks around us, especially at the University of Windsor. So your environment will prompt changes to designs that you read about. Because although this was a community project in stride, what my colleagues said was, well, listen, we have a 49-bed, long-stay inpatient rehabilitation unit for people with serious mental illness. And not only that, but we have lots of staff that can be involved, including rec therapists and dietitians. And those folks are there usually for an average of 3 months. And so, you know, what a great population to try this on. Now, here's TNI. What it looks like. Beautiful new building. And this is the healing garden outside. We have a greenhouse, we have a big gym. We have a lot of nice facilities. So we have a lot of students who get involved, who like to get involved in research. And we're starting to have regular residents as well in psychiatry. These are inpatients. They already have a lot of the data collected without having to do anything extra. We have equipment. They're I wouldn't want to say they're a captive audience, but the adherence might be better because they don't have to get on the bus and go anywhere. And the supplies that we have, many of them we have right there. This is our two recreational therapists. Aaron on the left is the one that's involved in our program. And so this is a great opportunity to get people involved who've never done research before. And they read a study like this, they get very excited. They think, well, geez, they know this is a big problem. You know, we never really know what to do. They were doing things with diet and exercise on the ward, but nothing in an organized fashion. And there were a lot of things about the design of the project that would be very, very applicable. And I think this stimulates people to start thinking, well, what could we do to change things? You know, well, we could actually do something here. So it was very exciting to see. So my third warning is that you have to count on coincidence, because I'm no sooner discussing this than I get this flyer in the mail about the SWAHN conference that's on nutrition, and I'm thinking, well, that's interesting. Maybe we should put it in an, you know, it's me getting in trouble again. So again, my colleagues will tell you that research is habit forming. So you know, now I start thinking about this as a research project rather than the other way around, right? So of course, I didn't think about a control group or anything like that. But as we start to think about that, we think, well, we have lots of history of patients who've been through the program. Maybe we could look at the old data. We could do something like that. But mostly we just see if this works in our setting. We have medical students and other learners who are very keen on getting involved and who will do an R&D application for us and get involved in the planning of the actual protocol. And I think most important about this whole project is this is something that has a chance to make a huge impact with our patients. And you can see that if this is successful, you can go to senior leadership and say, listen, can we continue to provide this as an outpatient program when people have been discharged from the hospital? If it works, could we disseminate it to other locations in the community, like we have a partnership with CMHA, could we do it there? We do it with Mental Health Connections, which is a recreational organization that's attached to our program, and so forth and so on. So I think a big chance to make a change. And not only that, but to give other people get them bitten with the bug and have them start thinking about research. Like Dr. Gilliland was saying, I think once you start trying it, I think the first thing I did was I got involved with all hats back when I was a family doctor, and that was a big hypertension project. And once you get involved, then you think about it all the time, right? There's, in your handout, there's the references that you can look through. These are a few other projects, similar projects, and this information about STRIDE, should you care to think about that for your own ages. And this is my granddaughter who eats everything. Do you have any questions?